everybody, and thanks for tuning in. I'm Sarah Beardon. I'm currently studying for a PhD at UCL, which is a joint project between the Department of Applied Health Research and the Faculty of Laws. I'll be speaking about the implementation of health justice partnerships, which are collaborations between healthcare and legal services to support patients with social welfare issues. I'll start with a brief explanation of social welfare law. It sets out our rights and entitlements as citizens to basic levels of support, for example, financial assistance, decent housing, fair treatment in our employment and education, and access to social care. When people cannot obtain the support they're entitled to, this is an unmet legal need, and it can result in financial strain, poor living and working conditions, and a range of other social consequences. This is probably sounding familiar to many of you because the conditions we refer to as the social determinants of health often have an underlying basis in the law and can be resolved through legal processes. So legal assistance is a tool we can use to address the social determinants of health and help to prevent illness and improve well-being. Legal assistance can include getting advice from a trained welfare advisor, as well as more in-depth casework support or tribunal representation. So why join up legal services with healthcare? I've mentioned that social welfare legal needs can affect health in a negative way. This is particularly a concern for health inequalities because levels of legal need are higher among the worst off in society. But it works in the other direction too. When we become ill, we're more likely to develop legal problems because we may lose our job and our income, or we might need housing support or social care. Delivering legal services in healthcare settings improves access to legal assistance, especially for people with mental health conditions, disabilities, and other vulnerable groups. So by integrating services in this way, we can facilitate access to the right help when and where it's needed, and address the interconnected challenges of access to justice and health inequalities. Health justice partnerships exist across the world with national networks across the United States and Australia. In England and Wales, we have no formalised network, but there are lots of services working locally. For example, Citizens Advice quite often do outreach work in healthcare settings, and Macmillan Cancer Support routinely integrate financial advice into their cancer care services. In terms of service models, we have lots of diversity too. Different types of legal services work in different types of healthcare settings and use different systems for linking up care between the partners. But the key ingredients are still the same: provision of legal assistance for social welfare issues in healthcare settings. There are some evident challenges in delivering these partnerships. There's quite a high turnover rate, and some seem to pop up and disappear again quite quickly, but there are also examples of some very long-standing and successful partnerships. There are also challenges in developing ways of working together effectively between the two services and getting the staff engaged and participating in the new approach. So the question I'm asking for my PhD study is, how can health justice partnerships be implemented successfully? What are the factors that influence how well these partnerships work, and how can they work effectively in different settings? I'm in the process of some fieldwork to explore this question, but in the meantime I've had a look at what the literature and theory can tell us, which is what I'll present now. So this is based on a review of international literature, and for this analysis I've used information from 78 papers. I used thematic analysis to look firstly at the content of the literature and then to frame that within the context of theory. There are lots of theories out there which help to explain how complex interventions can be implemented successfully in healthcare settings, and they can help us to understand the processes involved and why something might work well in one setting and not in another. The theory I've chosen to use is called the general theory of implementation, and it draws on existing theories in psychology and sociology to help explain how working practices can take root. Where it says contribution, that represents the work that people do to enact whatever the intervention is, in this case joining up care between health and legal services. But that work is constrained by the things above it. Capability, which is to do with how easy it is to engage with the system. Capacity, which is to do with the resources available for that work. And potential, which is to do with the social contexts that either facilitate or inhibit participation. I'm now going to run through what the literature on health justice partnerships says about each of these factors. Let's start with contribution. So what is the work that's involved in joining up healthcare and legal services? It does vary between the service models, but very often it's a referral-based system. So this would involve identifying legal needs among patients and referring to a legal service partner. But there are other things too. It might involve communication between professionals to discuss a person's needs. It might require information sharing, so for example providing medical evidence to support a welfare application. And there might be some kind of ongoing feedback so that the professionals involved are kept updated with progress. So how can this be facilitated? Capability to engage in partnership working is dependent on how the system is designed. It needs to be easy to use, simple and straightforward, and not creating lots of extra work. It should be designed appropriately for the local setting, so addressing any prevalent welfare needs of the local population and also any issues that the healthcare professionals come across regularly. The roles and processes need to be clear so that staff understand how to engage with the opposite service, and there should be opportunities for interaction between the staff in the two services. Locating the services together can help to facilitate that, but it could also be through other activities such as joint meetings. Capacity is to do with the resources for partnership working. Is there funding to support the work? Funding can really affect the sustainability of these arrangements. Is there physical space available to hold the appointments and host the service on site if it's needed there? Is there sufficient staffing and capacity to take on the referrals? And also, is there provision for learning? This helps to ensure that the professionals understand the purpose of the partnership and what their role in it should be. Sometimes this happens through training sessions, but more often it seems to be through informal promotion and awareness raising. And lastly, potential, the role of the social context. This can be a really powerful influence on whether a partnership succeeds or fails. Those participating in it, both the health and legal professionals, need to understand the rationale behind the partnership. What is the link between welfare and health? When would you refer somebody and why? And what difference does it make that you're working together as a team? Positive attitudes also make a huge difference. If participants buy into the idea and are willing to work with a group of professionals that they may not be used to working with. Joint goals. I mentioned at the start that these partnerships are often achieving things that are important to both the health and the legal services, and emphasising this can really help to build motivation for engagement. And last but not least, strong leadership that is positive and visible to those on the ground. Leaders can encourage joint working, bring people on board, and help ensure that the system is well planned, evaluated, funded and supported. So that's a brief overview of what the literature and theory can tell us. Thinking about these factors could help us to design and deliver health justice partnerships as successfully as possible in practice. There may also be things that are more or less important depending on the service model and setting, so that's something I'll be looking into as well. So what difference does this all make? I've reviewed the evidence on impact separately, but just to mention a couple of key things that are relevant to service functioning. You might expect to see improved case outcomes for individuals, both for their welfare circumstances and for their health, particularly mental well-being, and also improved service efficiency for both the health and legal services, for example through reducing medical time spent on non-medical issues and through more effectively reaching those in need of legal assistance. And what would be the signs that the partnership itself was doing well in practice? Successful integration, so having a seamless system for joining up care between health and legal services, which is well used and becomes part of routine service delivery. And sustainability, being able to continue those working practices over time and putting down stable foundations for the partnership in future. There's lots more to be learnt and discussed, and I'd like to thank the services across England that are contributing to this research and helping us to learn from local experience. Thank you very much for listening. I hope it's been interesting, and do feel free to get in touch if you'd like any further information.